The following is a presentation of Project Independence and WCWP. Project Independence is the Aging in Place initiative of the town of North Hempstead. Welcome to Project Independence and You.
Good morning and welcome to Community Talk Radio. This is Project Independence and You on LIU Public Radio. I'm your host, Rebecca Miller, along with co-host Otto Lohse. Good morning, Otto.
Good morning, Rebecca. It's always a pleasure.
Always. And of course, our radio show producer and the Director of Senior Citizen Affairs for Project Independence, Department of Services for the Aging for the town of North Hempstead, Kristina Lowe. Good morning. You're all in red, and we'll get to that shortly, I'm sure. This morning, we're talking about heart health and aging with Maura Calio, a community health educator and nurse with St. Francis Hospital at the DeMatteis Center. So thank you so much for joining us, Maura. We're so happy to have you here today.
Happy to be here. Thank you.
It's great to have you. And of course, February represents, I guess, in addition to Valentine's Day being in there, so I guess there's that link too, just kind of heart awareness. And it's perfect timing to have you on. I think during the break, before we started, we all started telling you about all of our different cardiac experiences. So, I think we all have something going on as we get older. But I like the topic as heart health. So, how do we keep it healthy? And are you ever really too old to change your ways? Sometimes people just say, well, I've always had this, and, I've always had high cholesterol, and is it really worth it at, maybe in my 60s, 70s, and 80s? I mean, can you turn things around as we get older?
It's never too late to make changes. And sometimes with older people, the changes might be fairly small, but still going in the right direction. I find that the senior population, they're really very interested in learning. So we get very good attendance at lectures and talks and things geared towards seniors. And, seniors have lived their lives. So they're not a population that you can just tell things to. The way that I usually approach talking to seniors is presenting them with information and asking them to figure out what that might look like in their own lives and what kind of changes they can make in little bits, because it's the small changes that endure. If you try to make huge changes, sometimes the change is so difficult that people throw it out the window. So if you hand somebody a whole bunch of papers and say, you have to follow this diet and you have to follow this exercise regimen, oftentimes it really doesn't make it beyond the garbage pail because it's overwhelming. So little changes are very helpful.
I have to agree. I think also because if you say you have to do all these changes, if you fail at one minor thing, you may just say, oh, I can't do it. So implementing slowly and kind of, it in a realistic time span and is really the best, I think, in all kinds of changes in life.
Yeah.
I'd like to hear a little bit about you, though, too, before we kind of begin the big picture of, heart health and aging. Where you're at now, you're at the DeMatteis Center, and how that relates to St. Francis, and maybe a little bit about your background and how you came into this field.
Okay. I graduated from nursing school a long time ago, 1978. And as a new nurse, started working at St. Francis on the open heart surgery floor, because at that time, the hospital was divided up with specialty on each unit. So my unit was open heart surgery. One of the units was orthopedics. One of the units was medical. And there is some specialization, but the hospital is much bigger now and has many more units. So I did go back to school for my master's degree in nursing education. So I've had many jobs and worn many hats in my years in nursing, but it's all nursing. Nursing is not only bedside nursing. So I did a lot in education. I taught in some of the major nursing programs on Long Island, and I've been in this position since 2016. And when I was hired, it was to fill two specific needs at the DeMattis Center. One was to coordinate stroke support for people in the community, and the other was to run a smoking cessation program. And then the rest just evolved the longer that I was in this, that I would do talks at senior groups and lectures in various situations. We run a fall prevention program, so I facilitate that, I organize it. We have a diabetes prevention program that's a year long. I'm a teacher in that as well. So it's really expanded into many different areas of need for people in the community.
So you've really been, you were a true Long Islander too, also working exclusively, it sounds like, on Long Island since you started. You know, your first job out of college or nursing school was working in the open heart surgery unit at St. Francis?
Yes.
So now you're kind of full circle, or have you always been in some way, I'm saying, you know, returning to St. Francis, or have you always worked for St. Francis in some way?
With one very short gap, I've always worked with St. Francis in some way. I was per diem for many years when I was raising my children. I worked, you know, part-time in cardiac rehab, always for St. Francis. I did work a few other jobs, but kept my per diem status here. So, yes, I have a long connection with St. Francis.
One other question too, like I find the open heart surgery, I'm sure, is so different today than it was back in 1978. I mean, the procedures that they did as kind of open heart, maybe today they're doing, you know, very differently, going in through arteries and things like that. What's some of the differences between then and now, what you would find in that same kind of unit?
That's a very good question. Not only that unit, the hospital has configured differently, but one of the biggest differences is there are many fewer traditional open heart procedures where the center of the chest was opened. And that's because of the advances in the ability to open vessels in a less invasive way. So when they're putting in many more stents, that's the little thing that keeps the vessel open. They're doing less invasive valve replacements. TAVR is the term that's used for the aortic valve replacement, where they go through the groin. They don't need to open the chest. There are many other minimally invasive procedures. So that's the biggest change, is that not all of these procedures are in the operating room. Many of them are in the cardiac catheterization lab. And the advances have been just unbelievable. I remember I worked on the third floor and watching the television somebody had on in their room, and they were reporting on this exciting new technique where they opened the vessel with a stent. And then it came to St. Francis. So St. Francis has always been a leader in adopting new technologies.
Well, I was a customer a year ago, November, and had a stent put in at St. Francis, and it was like an outpatient deal to talk the difference between 1978 and now. I went home that day, you know, had the catheterization. Yes, you need, you know, 90% blockage. You need a stent, and they did it, and I went home. I don't think that would have been the story in 1978. You know, it's pretty amazing. It really is.
No, in 1978, most likely you would have had open heart surgery and coronary bypass, which still is done today in certain circumstances. Say if somebody has multiple blockages and it's technically difficult to open the vessels with a stent, and it's going to be better in the long run to do bypass, they still do that. And there are certain people that are better candidates for bypass surgery than they are for stents, but far less than there used to be.
Did something like a nuclear stress test exist in 1978?
No.
Because that's how they discovered my situation. I went for the nuclear stress test, and they said, you really have to go for a catheterization because you got blockages. And
yes.
I had no symptoms to speak of, really. Just a very slight tightness in my chest.
There are a number of things available today that were not even thought about in 1978. One was the nuclear stress test. They were just doing a standard stress test, and all they could look for are changes in your cardiogram and changes in your blood pressure. So it offered some information, but wasn't very reliable. The other is two things: a calcium score and a CT angiogram. And many people could be sent for a calcium score. And the idea behind that test is that over time, calcifications can build up in the coronary arteries. And when you do a calcium score, it's a number. And that number from 0 to 100 tells you how much calcification is there. If it's very suspicious that you have coronary disease and you may have some mild symptoms, then they may do a coronary angiogram, which is injecting a tracer, and they use the CAT scan machine to look at, they actually come up with this beautiful 3D picture, which shows areas of the heart, the vasculature in the heart that are not getting blood supply and are likely blocked to some degree. And they can even estimate the degree. So it will then point to, what do we do next? Do we go right to cardiac catheterization?
That's interesting that you bring that calcium score thing up, because I would say in the neighborhood of 25 years or more ago, there was a little ad in the newspaper about St. Francis doing this calcium test. And I decided on my own to go there to have that test. And I found out as a result of that, that I had a problem, that my calcium score was high. And because of that, my cardiologist then started putting me on a program that was more aggressive, cholesterol medication, blood pressure medication. And it sounds to me now, reflecting back, that might not be a bad idea for people to do, just to get a baseline to find out where they stand. Your thoughts on that?
Many doctors are recommending it, particularly, not for everybody, but particularly for people that have risk factors. So say you have a family history, your cholesterol's always been a little, on the higher side.
Right.
Especially people with diabetes, they're looked at very differently because of the increased risk for heart disease. And I think at that time, Otto, it was called the ultra-fast CT scanner. And we had it here at DeMadison. We were the only hospital in the whole, I think, New York area that had this machine. So that was kind of the beginning. Those were the early days in looking at calcium to correlate with the degree of coronary disease.
Yeah, I found out my score was high. Mm-hmm. Fortunately, I'm still here because I found that out back then.
Because they aggressively treated your risk factors.
Right. And I was aware of them, which made me change a few things also, I think. And you're right about the small changes. Mm-hmm. It's very difficult to make changes for anybody at any time. But, you do have to do it every now and then.
Yeah.
I had a similar, but different experience about 5-6 years ago. Out of the blue, I had, it was diagnosed as AV nodal supraventricular tachycardia. Uh-huh. And I, of course, went to St. Francis. I wound up having a cardiac ablation. I was in this room for a total of 40 minutes and was not even put out, was awake the whole time because they wanted to make sure, I guess they didn't want to have to give me adrenaline to trigger the tachycardia, which they did not have to, because I was, at that point, it was really bad. I was back in, I guess it was the cardiac ICU, or not even the ICU, or the step down unit, whatever it was that day, within an hour. Mm-hmm. And for me, luckily, everything worked. Everything went wonderfully. And I too had to have the CTA a little later, for which happily I had 0 calcification and 0 plaque. So, but yet I still have high LDLs, but I have super high HDLs, but I'm still on medication, because no one likes high LDLs. No one in the cardiac world likes an elevated LDL. So
that's something that has changed. The focus used to be on the good cholesterol, the HDL, and
right.
The thought was, well, if you have a high HDL, you don't have to worry. And that is not the case anymore. With advanced research, that
right.
they look at the LDL number. And if you have no history of cardiac disease, under 100 is desirable. But if you have a history of stents, bypasses, any kind of cardiac issue, under 70 is the goal, which means that you're going to be on cholesterol lowering medicine.
Under 70
Right.
for LDL?
Yeah.
No, HDL. LDL?
LDL.
Under
yeah.
70?
Is usually the goal for somebody
Wow.
who has a cardiac history. And the whole reason is to try to prevent build up again in those stented vessels. That can happen. And that's why they continue aggressive risk reduction after those procedures, because the same atherosclerosis that happened in your own arteries, your native arteries, can happen in the artery that has a stent in it or in an artery that had bypass.
So that's a pretty big change, isn't it, from what the thoughts were on LDL before?
Yeah,
I thought
over
the number,
the past,
like, if you had 150, you were okay.
no.
LDL?
No.
Never. No, I think you're thinking of total cholesterol. LDL was always kind of
Okay, yeah, you're right. It's
definitely low.
200, like if you have a
Right.
total
You're thinking
cholesterol.
of total.
Total
yeah.
cholesterol under 200, but now really they like it 180,
A little lower,
So
yeah.
the hitting those risk factors more aggressively, they're finding prevents the return of atherosclerosis to those vessels.
Yeah.
And where does the
said, because
triglyceride fit in on that numbering thing?
Triglyceride is also, I think it's, don't quote me, I think it has to be under 150. I think that's the number you're thinking of. Triglyceride is a number that it worsens in people who have diabetes when the diabetes is not under good control. And high triglyceride also is a marker for heart disease in women. So those two populations, people with diabetes and women. So it's important to get that triglyceride under control.
Okay, you actually have to take a quick break. After the break, we'll continue talking about heart health and aging with Maura Calio. We'll be right back. You're listening to Project Independence in You on LIU Public Radio.
Take WCWP with you wherever you go with the WCWP app. Listen live 24/7 to all of our streams, all from one app. Plus, call the studios directly from the app and visit our social media. Download the app through the iOS App Store on Apple devices or the Google Play Store on Android by searching WCWP Radio, or visit WCWP.org for links. The WCWP app, available now on iOS and Android devices.
Welcome back to Project Independence in You. I'm your host, Rebecca Miller, along with co-host Otto Lohse, and of course, our radio show producer, Kristina Liu. We're talking about heart health and aging with Maura Calio, who is a community health educator and nurse at St. Francis Hospital at the DeMatteis Center. So before break, we were just talking about cholesterol and the procedures that Otto and I have had, and Maura's been kind enough to kind of go over all these things. I think that a lot of our listeners have probably in some way had similar things. There's always cholesterol questions. And, Maura, you brought up that LDL, it's changing now. They're not kind of looking to, have they stopped completely kind of looking at the ratio where it used to be, if you had a low ratio, you really didn't have much to worry about, or that kind of a thing?
It doesn't, the ratio is not as much of it doesn't play as big a part in decision making, because even the blood testing is more sophisticated. They break down the LDL to look at the very low density lipoproteins. I'm not an expert in those pieces, but I know that they break it down and they look at, okay, your LDL is 80 and your LDL is 80, but they may look differently when they break it down. And what they try to do is match the best cholesterol medicine with that lipid profile, or what your fats look like. So it's not just everybody should be on one or the other. It's not a one size fits all.
You know, I don't think we're trying to get anybody to be a doctor, but I think it's important for people to get educated themselves as to what these numbers are and what they mean, and maybe what you can do about trying to change those besides just medication. You know, the self-education in the medical world, I think we're half the battle. Uh, you have to be able to talk to the doctor about these things. So my point is, I think it's very important to get educated as much as you can without thinking you're the doctor. You know, you really have to know how to communicate with the doctor about this stuff.
You know what, Otto, what you're saying and what Maura said is kind of maybe Kristina, we need to have a guest on, even not exactly what you were saying, but like maybe from a lab that can talk about all kinds of lab results, blood results, biopsies, those kinds of things, what you're looking for, when we could kind of come up with questions like that down the road.
You know, I'm just one of the good things, like with my chart we talked about offline earlier, or a lot of the labs, they will now show you a trend of a number. Like I'll use PSA as an example for a man. You know, you can actually get like a 5-year graph that shows you where you're going with these numbers, like an LDL. You know, is it steady, or are you kind of spiking your way up? Those are numbers that, to be honest about it, maybe the doctor doesn't quite have enough time to look at, but it doesn't hurt for you to look at it.
I agree with you that if you're able to tap into those My Chart portals, it does give you a graph. And one of the other things that's good to track, aside from actual numbers for cholesterol, is some of the other trends, is the hemoglobin A1C. It's a measure of whether somebody has prediabetes or diabetes. And we know that the longer someone lives, the higher their likelihood of developing prediabetes, possibly diabetes. And those are the things that, if they can be avoided or delayed, will be an asset to their overall health. And when you look at those trends, the hemoglobin A1C number, that we want to trend down instead of up. As people become more sedentary, they gain weight. They may not be paying too much attention to how they're eating, particularly people that live alone. They may just eat what's easy. So realizing that other things add to that risk, like blood pressure control, diabetes control. And it is easy to look at it on the My Chart portal if you're savvy enough to know that.
You said the word blood pressure, which is another area that we all, I think, know a little bit about. But how, like, if you go to the doctor once a year, once every 6 months, and that's the only time you get a blood pressure reading, that's probably, in my judgment, not too good. You probably ought to be able to find out what your blood pressure is a little more often. What's your view on that? And also being able to take your own blood pressure with devices that exist now.
Would we be able to? That's a great question. And blood pressure is something we really need to get in. But I know that one of the things, can we just talk maybe about, how does the heart work? How does it change with age? And then kind of from there, get into the whole blood pressure view, just to kind of give our listeners a little bit more of a background, and then talk specifically about blood pressure, which is a huge topic as we age.
So, well, when I talk about the function of the heart, blood pressure is in there, The heart is essentially a pump, and it doesn't get any vacations. It pumps 60 to 100 times a minute for your entire life. And it's a muscle that needs to be kind of maintained like a car. So one of the things that can adversely affect the function of the heart, particularly as people get older, there's many things. One is that some people develop problems with the valves in the heart, the little doors that open and close between the top and the bottom of the heart, and when the blood flows out to the body. And it can cause the heart to have to work harder. There are many, many diseases that can affect the heart that can be acquired in older age. So that's why going for a physical every year is so important for many reasons. At a physical, you'll have an EKG. EKGs can pinpoint problems with the heart rhythm. And also, if you've had any insult to the heart and didn't know it, for instance, a mild heart attack, that can happen, that people don't even know that they had a heart attack. If your blood pressure is not well controlled, that over time, that will make the heart work harder, and the muscle, as it's overworked, the muscle gets bigger and bigger. That's called cardiomyopathy and cardiac enlargement. So that will lead to that pump getting weaker and weaker over time. So these are the things that, in general, people need to do to maintain heart health. We treat high blood pressure in young people all the time. When I got out of nursing school, if you had blood pressure that was higher, it was like, don't worry, you're young. We don't have to do anything about it. The normal parameters are much tighter for blood pressure now when you decide whether somebody needs blood pressure medication. Seniors, if they take blood pressure medication every single day, then it is good to have that check-in. Like Otto said, many people have blood pressure machines at home that are fairly easy to use. You press a button, it does your blood pressure. The doctor may, if you're not inclined to do that, the doctor may have you coming back every 3 months to have it checked. The other things that are available, and this is just a little highlight for the Catholic Health and St. Francis, is we have an outreach bus that is out 5 days a week at various community sites. And on that bus, the nurses will take your blood pressure. They also will do a finger stick little blood test for total cholesterol, good cholesterol, and blood sugar for diabetes screening. We also do blood pressure testing at many of the local libraries every month. So there are places to go and check in between your doctor visits.
Yeah, one of them, frankly, Project Independence has nurses that will actually go to people's homes and check blood pressure.
Right.
And that's at no cost. So
Right.
that's a good deal.
Yeah.
One of the things that you brought up when we were talking just before, and I'm very curious about, you talked about the EKG and how it can tell if somebody had a minor heart attack. So I have so many questions about that are probably, how do you not know you had a heart attack? And what exactly is a heart attack? I mean, are there different kinds? I mean, you hear the word heart attack and it just feels like it's such a big umbrella over so many different things that are referenced, especially one, if you could have one and not even know it.
I had that, all right, and I found that out in my nuclear stress test. They said, you probably had a heart attack, moderate, but you had a heart attack like 25 years ago or whatever.
Moderate? Wow.
Yeah, well, I'm lucky. As I said, I'm very lucky I'm here. I mean, I got a lot of things that, came along that I was fortunate enough to find out about. Although that particular event, I look back, I was on a golf course. It was a very hot, sunny day.
And so you think you know when it happened, Otto?
I think I do, looking back, but that didn't enter my head. I thought, oh, it's hot. I was dehydrated, blah, blah. But no, I don't think so. I think that was actually a heart attack event of maybe a mild nature, but I remember feeling like electricity almost or whatever going through me. It was a weird feeling. And then when I tried to drive my car, I had a hard time. But, I was younger and dumber than I am now. You know, and I'm still got some ways to go. But I mean, uh, yeah, I did. I mean, and it was showing up on the nuclear stress test, which I
So we hear heart
totally.
attack, right? What does it actually mean, and what different kinds are
Well, that's a
there?
good question. I mean, I was
Right.
told that it looked like I had a heart attack based on the nuclear stress test, which to me, frankly, is a very, very valuable tool because that's how they found out a lot of things. And it almost seems like if there's any question about it, you ought to go for a nuclear stress test.
Okay, to answer your question, a heart attack means that one of the major vessels that supplies oxygenated blood to the heart muscle has become blocked. And this is not something that typically just happens overnight. The buildup of fatty plaque in the artery can take years. And the final blockage or occlusion is a blood clot, because the walls of the vessel aren't really smooth and straight anymore because of the kind of the encroaching of the plaque. So when the blood supply to the heart muscle gets blocked, if no intervention takes place, that area of heart muscle dies. Once it dies, it cannot be restored. So picking up that someone had a heart attack, first I'll talk about an EKG, is it gives a particular appearance on the electrocardiogram that indicates damage to the heart muscle. So, you've heard 12 lead EKG. So people that are expert at reading EKGs can look at certain ones and say, this was a heart attack in this specific area of the heart. And they can pretty much predict what vessel was involved. What Otto was referring to on the nuclear stress test is that during a nuclear stress test, they inject a nuclear tracer and they have you exercise and then they scan your heart. And what they see if somebody has previous damage is that area of the heart does not take up the nuclear substance. So it's like a little desert. It just doesn't pick up the radionuclear tracer. And they can say this area of the heart was damaged in the past.
And what I think now we're trying to recall for sure, that they saw the damage and they said your body basically kind of rerouted its way around that area, which to me is pretty amazing.
What that's referring to is it's called collateral circulation.
That's the word, right?
The bigger vessels can grow small vessels, but it doesn't completely reverse the damage. That damage is there forever. So it can supply enough circulation that your heart will function okay. And it just depends on the size of the heart attack, the size of the area that's damaged. So yes, there is some ability to grow kind of new plumbing to certain areas.
And the new plumbing, they said in order to get a stent there, it becomes very complicated. And it's not like you just show up for an outpatient procedure like I did. So they said it's working okay, you're good. It's not going to kill you, basically. But the word collateral damage to me was kind of like, wow, you're lucky your body can do that.
Collateral circulation.
Circulation, right.
Yeah. So it all depends on which vessel was involved and whether it is that person's dominant blood vessel. So some people have a bigger right coronary artery. Some people have a bigger left coronary artery. Some people have a bigger circumflex. Those are the three major blood vessels. But if the one that's the dominant one becomes blocked, it can be a life-threatening situation right in that moment. And I also just wanted to address why some people don't know they are having a heart attack.
Right.
And you see that often in people who've had diabetes for many years. And that's because the autonomic nervous system is the nervous system that is what causes the typical chest pressure and radiation down the arm and pain up to the jaw. In someone who's had longstanding diabetes, there's damage to the autonomic nervous system so that you don't get those typical pain, pressure, fullness feelings. So it can be an after the fact discovery, or it can cause sudden death.
You know, there's another term that I want to discuss, but we actually have to take a quick break, and we'll get back to that after we take our quick break. We'll continue talking about heart health and aging with Maura Calio. You're listening to Project Independence in You on LIU Public Radio.
WCWP is your home for great music and great conversation. You'll find all that and more on WCWP.org. Listen live on the web, check out the lineup, subscribe to podcasts, and stay up to date on the latest station events. Get in touch with us and let us know if you like what you're hearing. And find out how you can support or get involved at the only community public radio station serving Nassau's North Shore. Plus, sign up to get a free bumper sticker. It's all online at WCWP.org.
Welcome back to Project Independence in You. I'm your host, Rebecca Miller, along with our co-host, Otto Lohse, and of course, Kristina Liu, the radio show producer. We are talking about heart health and aging with Maura Calio, and she's a community health educator and nurse with St. Francis at the DeMattis Center, and we're just getting so much incredible information. Just wanted to point out one thing that Maura will be speaking at our next advisory meeting, which I believe is February 21st, which will be at Clinton G. Martin Park, right here in New Hyde Park. So we'll looking forward to that as well. We want to thank you too for that. Maura, right before break, one of the other terms that you hear that, you know, kind of like a heart attack, what does that really mean? You hear that people are in heart failure a lot. And that just, to me, is very scary. I mean, it's a very scary thing to hear. And it could be somebody that's had it forever. You know, when you hear heart failure, I mean, when something fails, you're thinking, you know, that's it. But I don't know that that's the case. But could you talk a little bit about that?
Sure. When someone is in heart failure, it means that the heart pump has weakened. And what happens as a result of that is that the whole flow of blood out through the body and then back up into the lung system where blood gets oxygenated, it kind of gets all backed up, because the pump is just not circulating everything effectively. What you see in someone typically who's in heart failure is swelling of their ankles. If they get on the scale, they may have a big jump in weight and shortness of breath. When you listen to their lungs with a stethoscope, often you hear crackles, which indicates fluid in the lungs. So, you know, the cardiac system and the pulmonary system are very intricately related. So the way that that's treated in people, and this isn't something you typically will see in a younger person unless there are structural problems with the heart. So it usually develops later in life to people, number one, who have had long-standing, poorly managed high blood pressure, because the blood pressure, when it's not under good control, it means that when the heart is pumping blood out into the aortic arch and through the body, it meets more resistance. And when the heart has to work harder, it weakens the muscle over time. It's like overwork. It's like climbing hills in your car only. It never gets any breaks. So the way that heart failure is treated, and many people are treated for heart failure successfully for many, many, many years, but they have to stick to a particular regimen. One of them is reducing the amount of sodium in their diet. And that's why many older people, many seniors are told to watch the salt. And that's easy to say, but hard to understand. So it's worth it for people to meet with a dietitian, to go to lectures where dietitians talk about how you actually can eat when you're on a sodium restricted diet. And the other is paying good attention to the control of your blood pressure. So that those are some people who do monitor their blood pressure at home or have it checked frequently. And they're asked to weigh themselves to make sure that they haven't had a big jump in their body weight. When you start to give people water pills and diuretics to treat heart failure, some people are on diuretics all the time for it. They may lose 12 pounds in a few days because they've accumulated so much extra water that isn't gotten rid of because of the heart not being optimum.
Is congestive heart failure and heart failure kind of the same thing?
Yes.
Yeah, okay. And can somebody get to a point with congestive heart failure? Unfortunately, I have a friend who was in that category, where they get to a point where there's not much that can be done.
Yes.
Okay.
It's a matter of degree. So
Right,
that's
right.
why if somebody has congestive heart failure, they're put on a specific regimen of medication that helps the heart pump, relaxes the blood vessels as the blood is leaving the heart. They're put on water pills, maybe more than one. They're usually on multiple medications that will help support the heart because it's weakened.
Now, some of this, I assume, is brought on by maybe bad health habits over the years, weight gain, diabetes. But is there, and there are conditions, I assume, that are just genetic? I mean, healthy people that may have conditions like this, or is this more kind of brought on by lifestyle?
It can be either. Well, if you're talking about true genetic conditions, there are people that have terrible cholesterol levels that run in families, and it doesn't matter what they eat. They have people that have very out of control blood pressure and difficult to manage blood pressure that can run in families. People who have kidney disease may be at more risk for the effects on the heart. People that have valvular disease, it can lead to some heart failure. And some people are candidates for surgical repair and some people are not. Lifestyle, for sure, poorly managed diabetes and diabetes over many, many, many years can cause damage to the heart. There's a very long list of and other acquired diseases that I really can't talk in depth about, but I'm aware of them. People develop sarcoidosis that can affect the heart muscle, amyloidosis that can affect the heart muscle. But the good thing is that the testing for heart issues is much better than it used to be. Yeah. They utilize the MRI of the heart to look for some of those unusual conditions. People who have had myocarditis, which is caused by a virus, usually causes inflammation of the heart, they may use the MRI to look at how the heart is functioning during and after this episode of myocarditis. You've seen that with COVID as well, that there were people who developed myocarditis, which simply means inflammation of the muscle.
Interesting. I know Otto during break wanted to talk a little bit about a great thing that
I had
a
personal experience which hopefully can relate to other people and gain from it. When I was in the Navy, 19 years old, I have a record that shows this in writing. My blood pressure was 140 over 100. And looking back on it, they used to tell you that 100 plus your age, you were good. I'm sure when I was in the Navy, the last thing on their mind was the fact that that blood pressure was high. But as a result, I learned early in my life to look into this stuff. And I think I was about 30 when I went on blood pressure medication. So it's been a long time deal. So we're addressing seniors, but I think seniors should also be thinking about their descendants, if you will, their children, their grandchildren, to kind of encourage them to pay attention to these kinds of things. because you're not immune to it at a young age, and it makes it the earlier you can find out you have issues, I think, the better off you are in terms of hopefully managing it and being around for a while. So that's all. It's just an editorial comment. Uh,
So you have to you have to tell your family members, and because
I
doctors
have, trust
today
me.
do a lot of risk factor checking. Would your father side you now? I know everything about my mother's side pretty much, but I don't know a lot about my father's side. So it is really important to know kind of what predecede what other people in your family have had that could be genetic. So it's good
Well,
that you
like
do that.
I'm first generation. My family came from Germany, and I have zero knowledge of what was wrong with anybody back there. My father and
Right.
mother both had high blood pressure, so clearly that's an issue. Uh,
Yeah.
but I'm
Yeah.
getting creeping up there in the years, and I'm still here. So I think a lot of that is attributed to the fact that uh, you try to do what you can to keep going and prevent it from becoming a disaster. Um, that's
How
all
about
I can.
exercise, Otto? Have you ever exercised?
Well, yeah, I guess that's the point too, is that I've always was into sports, and I've always been a walker. Where I grew up, you had to walk. We didn't have a car, so walking was how I got places, and I like to walk. So I still walk now. Like yesterday at the beautiful grounds at the Dematis Center, I walk a half an hour around through the grass and up through all the roads up there, and it's a nice walk. There's a couple of little hills, uh, but I've always walked, and I like to walk, and I attribute that to some of the luck I've had. In maybe not going down the tubes as far as some of these other things are concerned. So yeah, I'm a big believer that you need to do something. You got to move. You can't
And
just sit. That's the
and you're never
worst.
really too old to start exercise. I mean, you can exercise on a chair. It's one of the things we like to talk about, Maura, too, is you're even if you've never done anything, it's never too late to start even the simplest kind of stretching, weights, that kind of a thing.
It is never too late, and it's a good idea to look for things in your community that are offered. The libraries have many resources for things like chair yoga, and yoga doesn't sound like a physical activity, but you're moving. So more moving than you were doing is a plus. Many older people have become sedentary. COVID made us all sedentary. So we're kind of fighting our way out of that. But if you're inclined to use a computer or a laptop, YouTube has instructional videos for absolutely everything. It could be wall Pilates, it could be chair yoga, it could be just morning stretching. If you're not that disciplined to do it on your own, you need to sign up and go to a class. We do have some at the Dematis Center for several different kinds of yoga. We have a class that is like Tai Chi. It's called Moving for Balance, which is perfect for older people. It's a safe way to move and work on your balance at the same time. And community centers. A lot of community centers have programs that people can participate in. The Herrick's Community Center, it's actually anybody in Nassau County can take classes there. They have a nutrition program. If you tend to eat alone, you can eat there. So there are resources around, and with a little bit of searching, it's good. And join with somebody. Exercising alone is not something that I'm ever motivated to do. I'm much better with I'm walking with someone, exercising with someone.
The
Well,
good
you're
news is most of
perfect
our
lead in
listeners
for
are project
Rebecca.
independent. One second, Otto. Most
Yeah.
of our listeners are residents of the town of North Hempstead, and we have an extensive fitness program.
Yes.
You can also watch it on North Hempstead TV, because a lot of the older generation may not really be watching YouTube. So you can still access 7 days a week, yoga, Tai Chi, gentle fitness. We also, at the town of North Hempstead, run 17 fitness classes for seniors each week at 5 or 6 different locations within the town. You can always call 311. We do Tai Chi for balance. We have chair yoga, mat yoga. We do Zumba Gold, dance for fitness, chair fitness, low impact aerobics. So there's great emphasis on senior fitness in the town of North Hempstead. You only have to call 311 or 516-869-6311. I just wanted to mention that because most of our listeners are, residents of the town of North Hempstead. So there are other options too within Nassau County. So you're not limited to just North Hempstead, but we have a lot going on. Otto, sorry, I know that I interrupted.
No, actually what I said was that Maura was a perfect lead-in for you.
There you go. I was going to go anyway. I'm also a yoga instructor.
I was just trying to soften it up a little,
So much of this information is, it's just endless. And, we're so looking forward to you coming to the advisory meeting. Is there a way for people to get in touch with you or find out more information about the DeMatteis Center on all the different programs?
Sure. They can call 516-629-2013 is the Department of Community Health. And if they call, we can mail them one of our brochures that has all of the programs in it. It's called Wellness Matters. We do bring them to the local libraries and some of the groups, but we can mail one right to your house. And most of them are also on the website. The same, if you have to go to Catholic Health and choose St. Francis, and then I think there's a link that says community or community education that has many of them on there. But the Wellness Matters brochure is nice. It's a little book, you through it.
You know what?
And we can also help connect.
Yeah, I'm sorry, but the reason I was there yesterday is that my wife was there to the Women's Center at the DeMatteis Center, where they do a lot of different things and tests and whatnot.
Yep.
What is, we hear a lot about this, Otto. I'm glad you brought up your wife, because my next question was going to be, you hear a lot of the differences between heart health for men and women, maybe not necessarily how we exercise and eat right, but what happens when a man might be suffering a heart attack versus when a woman is, the different signs, or, and why is that, if you know why, that there are different patterns and signs?
Okay. First, a little history quickly.
Okay.
This is American Heart Month, which is for men and women. That has been in place since 1964. It was Lyndon Johnson who first issued this proclamation, and it's declared annually by every U.S. president since then. The Go Red for Women movement was started by the American Heart Association, and it focuses on and advocates for women and heart health, because many of the early research studies on heart disease had cohorts that were all based on men, so that it wasn't translatable to women. When someone has a heart attack, still the most frequent symptom is chest pressure, cold sweats, pain in the left arm. But women, sometimes it's much more vague, and that's why historically they were dismissed as either being tired, overwhelmed, hysterical, because they would come to the emergency room with,
unfortunately, Maura, I am so sorry. This is such an important topic, but this is the end of this segment. We will have to pick up. Thank you so much for joining us today. We'd like to thank you in St. Francis, and for allowing us to have you for all this time. And thanks for everybody who is listening. You're listening to Project Independence in You on LIU Public Radio.